Dear Chairman, dear colleagues, thank you for having me here in Barcelona and giving you this presentation on recommendations for appendiceal neuroendocrine tumors. And if we talk about recommendations, we have to rely to some recommendations that have been published, and the ESMO guideline, unfortunately, although it's very useful on other gastroenteropancreatic neuroendocrine tumors, does not state a lot about appendiceal neuroendocrine tumors, while the Northern American NANETS guidelines published in 2010 does so, at least to some degree, and the European Neuroendocrine Tumor Society guidelines of 2012 have a subchapter on appendiceal neuroendocrine tumors, so I will also rely a lot on that. So, as you know, it has been discussed and assumed that the incidence of neuroendocrine tumors is rising, and if you look particularly to appendiceal neuroendocrine tumors, at least in the SER database, there does not seem to be such a great increase as for other entities. But if you look into this European study from the UK, you see that there is a substantial increase in the incidence of appendiceal neuroendocrine tumors in both genders, male and female. So we can conclude that the probable annual incidence is between 1 and 5 per 1 million inhabitants per year, and that there is still a slight female preponderance. And certainly there is, in our experience, not a non-causative, but a relation to appendicitis and appendectomies, because most of these neuroendocrine tumors are found incidentally on appendectomy. And the mean age at initial diagnosis on average is approximately 10 to 12 years earlier than for other neuroendocrine tumors within the gastroenteropancreatic system. This population-based study from Austria from 2010 nicely depicts that the appendiceal neuroendocrine tumors are in fact actually a pretty large subcohort of all neuroendocrine tumors, although they only include a very small portion of malignant, so it means metastatic neuroendocrine tumors. But as in this study, 10% of appendiceal neuroendocrine tumors may actually appear malignant with distant metastasis, as has been shown here. And in this study, in fact, even one poorly differentiated endocrine carcinoma is reported within the appendix. However, it may be questioned whether this neuroendocrine carcinoma within the appendix is really a neuroendocrine tumor by the usual definition means, or whether it is a goblet cell phenotype neuroendocrine neoplasia. And this is important. It has been very nicely described in this review by Deschamps and Couvillard in 2010. There are two types of endocrine neoplasias which may arise in the appendix: the appendiceal, kind of typical carcinoid tumors or neuroendocrine tumors of the appendix, as shown here on the left panel in H&E stain with a relatively monomorphic cell phenotype infiltration of the muscularis propria, and on the left lower panel expression shown by immunohistochemistry of serotonin in this example, of hormone expression in these tumor cells, and a very low proliferative index on the right lower panel. On the other side, there are the goblet cell carcinoids, which may also arise rather frequently within the appendix, and they are characterized by the goblet cell phenotype within the tumor islets, as shown in the upper panels, and they can also present immunohistochemically with a neuroendocrine phenotype, as shown on the right lower panel, by expression of chromogranin A. So these two entities carry a neuroendocrine phenotype by immunohistochemistry, but also provide two different entities by tumor biology and by prognosis. So the classical neuroendocrine neoplasia histopathology does not only include the H&E stain, but it is required to show synaptophysin and chromogranin A positivity, as shown on the right panels, and should also include Ki67 staining for appendiceal neuroendocrine neoplasias just as well. However, I will come back to that later again. It has not been studied in appendiceal neuroendocrine neoplasias yet. So in general, neuroendocrine tumors of the appendix are rather small. The majority of them, between 60 and 80%, probably smaller than 1 centimeter, maybe even more. But there is a portion that is bigger than 1 centimeter, many of them bigger than 2 centimeters, but also there's an intermediate group of between 1 and 2 centimeters, as you see here as a summary from several publications. And most of these tumors are located at the tip of the appendix, but some of them also in the mid portion and at least up to 10% also at the base of the appendix. The size of the appendix of the appendiceal neuroendocrine tumor is important with regard to metastasis and also to prognosis, as has been shown in this analysis by Landry et al. On the right, showing you that if the tumor is smaller than 1 centimeter or between 1 and 2 centimeter, the prognosis is excellent. However, if the tumor gets bigger than 3 centimeter, the prognosis becomes much poorer, and the reason for that is the higher metastatic rate, as has already been shown by Charles Myrtle in 1987, but has been again found by others. So this analysis of the SEER database, actually published only in the North American guidelines, shows you nicely in the green line the prognosis of appendiceal neuroendocrine tumors in the SEER database. And as you can see, the localized and the local regional tumor stages have a very good outcome and very similar outcome. And in fact, there is not a big difference between the two of them. However, if you have an advanced metastatic state, the outcome is much poorer, even poorer than in jejunal-ileal tumors. However, keep in mind, it may not be a very clear distinction have been made in the SEER database between goblet cell carcinomas and neuroendocrine tumors as we define them today. But you can't do that prospectively if you don't know what the definition will be in 10 years, obviously. So the goblet cell carcinomas, just to make a short point of it, because it is a differential diagnosis when you have a patient with immunohistochemically positive features of neuroendocrine differentiation. So the goblet cell carcinomas have a partial neuroendocrine, but also a partial intestinal goblet cell differentiation. So there's a mixed phenotype, and thus they have been termed mixed endocrine-exocrine tumors or mixed adenoneuroendocrine carcinomas for the new, with respect to the new WHO classification of the year 2010. And this is, in fact, well justified, because in this nice study from the Netherlands, you can see that in the left column, you can see the goblet cell carcinomas, and next right to it, you see the typical carcinoids of the appendix. And you can see that the goblet cell carcinomas do express some immunohistochemical markers that are very characteristic of adenocarcinomas, like CEA or say like CK20, while neuroendocrine tumors or carcinoids do not express these. If you look a little bit below, unfortunately I do not have a pointer here to guide you through this table. If you look in the 2 lines below, you see the neuroendocrine markers synaptophysin and chromogranin A, as well as NCAM or CD56, and you see these are by majority expressed in the carcinoids, but also in a large subportion of the goblet cell carcinoids. So this really illustrates there is a biological heterogeneity, and the phenotypes may be similar, and a clear distinction is important in for these patients. Because if you look at the Ki67 labeling index, as they've done in this study as well, you can see that in classical carcinoids, abbreviated CC in the second line from above, you see the mean Ki67 index is about 2%, while in the goblet cell carcinoids, GCC, the Ki67 index is is almost 27%, while in adenocarcinomas it's about 40%. So obviously this relates also to prognosis, as has been shown in a different analysis shown here, with the upper line representing the neuroendocrine tumors or carcinoid tumors, and the second line from above in this Kaplan-Meier analysis representing the goblet cell carcinoids, and further down other types of adenocarcinomas of the appendix, in fact. So what is the current recommendation for classification? It's WHO 2010, who else? And this relates largely, as has been shown already in the previous talk, on the proliferative index as determined by Ki67 labeling index, and has been recommended for all neuroendocrine tumors from the gastrointestinal tract. What you can see is, or what needs to be mentioned at this point, is that the Ki67 index staining has been clearly shown to be of prognostic relevance for that examples given here for all gastrointestinal tumors, non-selecting where they originated from, for mid-gut neuroendocrine tumors, or for pancreatic neuroendocrine tumors, and there are many other studies showing this, for example, for gastric neuroendocrine tumors just as well. But there has no study been published on appendiceal neuroendocrine tumors. So it's a recommendation to use Ki67 on appendiceal neuroendocrine tumors, but it has not been prospectively studied, and therefore interpretation has to be done in the context of other criteria. So what is important at this point is the TNM staging, be it pathological or clinical, of appendiceal neuroendocrine tumors. And unfortunately, there are two competing classifications out there now, the one by the European Neuroendocrine Tumor Society, ENITS, and the other one by the UICC and AJCC, as shown here in the column. And you can see there is a difference only within for a few early tumor stages, PT1, PT2, and PT3, or PT1B and PT2 and 3 for the UACC, AJCC. And this also relates to some differences in staging classifications, which I will not go into much detail at this point. But at least what we know is that there is some evidence for a classification that relates to these from this analysis made by Landry et al. In 2008 using SEER data. And she has used a classification very similar to the AJCC classification that is presented on the right row, only referring to the tumor size of the appendiceal neuroendocrine tumor. The difference to the European Neuroendocrine Tumor Society classification is that the European Neuroendocrine Tumor Society also relates prognosis and tumor stage to the infiltration of the mesoappendix, explicitly the extent of infiltration of below or beyond 3 millimeters. For the diagnostic procedures, there are several situations one can imagine for neuroendocrine tumors. An initial staging on initial diagnosis is rarely the case in appendiceal neuroendocrine tumors, because usually you find it incidentally on surgery and you don't have a preoperative but rather a postoperative staging situation in these patients with the aim to detect residual disease or recurrence. And usually in these cases you use indirect imaging techniques, MRI, CT scanning, or sonography if you can use sonography at a very high level in your institution with a high frequency a probe for detection of a neoplasm in that area. But you know that this is a very low sensitivity in general. And there is the rare case of a malignant, progressive metastatic disease in which you do not get the patient cured or rid of the tumor load, so you have a palliative follow-up, and in these cases you want to measure disease progression. Again, you use the usual staging methods. Somatostatin receptor imaging obviously provides an important option in these patients, particularly for detection of distant metastasis. However, there is no explicit publication only studying appendiceal neuroendocrine tumors due to the rarity of the disease, so we just relate to what we do in other neuroendocrine tumor diseases as well. Chromogranin A may be a valuable tumor marker in advanced disease with a significant tumor load, so with a significant amount of tumor cells releasing this tumor marker. But if you have an early stage, very small disease of less than 1 centimeter, you hardly will find an elevated chromogranin A, so it's only very limited value in these patients. So how about the treatment strategies? Obviously, surgery is the most important treatment strategy for these mostly early stage diseased patients. And it's very simple. If you have a tumor smaller than 1 centimeter, you have essentially a risk of 0% for metastasis, and these patients are cured by simple appendectomy. The situation still seems pretty clear in patients with a tumor bigger than 2 centimeters, because these patients have a substantial risk of developing metastasis immediately or in the long run of the disease, and right hemicolectomy is recommended for these patients. However, you may encounter, and it's not as rare as one may think, the patients with a size in between. Tumor size between 1 and 2 centimeters, and in these patients, very rarely but surely, metastasis has been reported. And if you think of patients at a rather young age of initial diagnosis with even a long-term risk of metastasis, you may want to consider that appendectomy is not curative in these patients, and you want to consider them as candidates for right hemicolectomy. But who is the right candidate for that? And additional criteria have been suggested, and obviously resection status is important. And if you and particular patients with the location of the primary tumor of the appendiceal tumor at the base of the appendix, where it originates from the cecum, they are at risk for an R1 resection, a simple appendectomy, and these patients are very good candidates if they have this size and an R1 resection for a right hemicolectomy. And as I've told you before, alluded to at least before, patients with a PT3 tumor with a deep infiltration of the mesoappendix by pathological staging of the resected mesoappendix. This has to be stated in your pathology report, or you have to ask your pathologist what the status is with regards to that. These patients are also candidates for metastasis and therefore for right hemicolectomy. Ki-67 grading, particularly a G2 grading of beyond 2% has also been suggested, but as I told you before, not been studied. So particularly in this group of 1 to 2 centimeter patients, not so frequent, but when you see them at an early phase in their life, and it really matters to them. Will I be free of tumor disease or not? Particularly in these patients, you have to discuss the options, the risk factors, and also the comorbidities potentially resulting from right hemicolectomy. As a gastroenterologist, I probably don't consider them very severe, but there is some comorbidity which has to be discussed with the patients, and we've seen very rare cases with long-term comorbidity as well. So that surgery cures the patients very well has been shown in a couple of studies, here again presenting the SEER data analysis from Landry et al. Of 2008. And as you can see in stage 1 and stage 2 tumors, there was never a death from disease, and these patients have a very, very good long-term outcome. Particularly on the left panel, you see the tumor-specific survival, so stage 1 and stage 2 patients never died of their neuroendocrine tumor disease in this analysis. Others have also argued for a very conservative surgical approach, funnily enough, surgeons themselves, with only appendectomy being sufficient, in their opinion, for a cure of these patients, as has been published in 2006. However, others have studied their cohorts on a more multicentric base and have seen some degree of metastases in right hemicolectomies performed after appendectomy on the initial surgery. So what this means is there is some uncertainty about when to perform a right hemicolectomy in this intermediate-sized patients. And this is also shown by an analysis from Greece summarizing 12 patients with appendiceal neuroendocrine tumors which have undergone right hemicolectomy. And again, in 25% of this small series, the patients had showed some residual disease. So it's not absent the risk of metastasis, although it's not frequent. It's a difficult, really, truly clinical situation. There are no guidelines to make you sure that you're doing the right thing. So how about palliative treatment? Obviously, in the very rare situation of a metastatic neuroendocrine tumor from the appendix, you can use for liver disease TACE, TAE, SIRT, or RFTA, as has been discussed, for example, also on the previous session. I'm not going into details. For the extremely rare situation of symptomatic disease, biotherapy with somatostatin analogs is an option, as it is also for proliferation control. Alluding to the PROMET data, which were able to control disease progression in jejunal-ileal neuroendocrine tumors, and we assume that the appendiceal neuroendocrine tumors are really similar to the jejunal-ileal ones, and that you may treat them with somatostatin analogs for proliferation control. Chemotherapy probably does not play a role. Maybe temozolomide is a monotherapy, but it's only a guess, and there have been only a few cases published. For the rare, poorly differentiated G3 neuroendocrine carcinoma of the appendix, obviously platinum-based chemotherapies do provide an option, and targeted therapies may also provide an option. But all of these have not been studied in appendiceal neuroendocrine tumors in particular, so there is some uncertainty. What may provide a very good option, though, is the peptide receptor-mediated radionuclide therapy in the case of sufficient somatostatin receptor expression, even as a first-line treatment in the metastatic patient, and you may want to consider that. So how about follow-up? And this is the last topic. We may want to look into this publication by Charles Myrtle from 1987, where he reported on 12 patients with appendiceal carcinoids bigger than 2 centimeters, only treated by appendectomy, and a resectable metastasis was found in follow-up 29 years later. So you really have to care for your patient for a long time. And it has never been seen in a median follow-up of 11 years in the patients with right hemicolectomy. So the recommendations are as follows. For stage 1, so smaller than 1 centimeter tumors, follow-up is not required, assuming that an R0 resection was performed. For the intermediate group, probably a follow-up is not required as well if there were no risk factors. And for the more advanced tumor stages, the guidelines recommend 6 to 12 months intervals for the first year and then annual staging intervals in these patients using indirect imaging modalities and maybe chromogranin A. However, none of these modality has been studied in these patients. And you may, if you think of 29 years of annual CTs of the abdomen, you may consider that in younger patients you do not want to expose these patients to the radiation. So MRI may be an option, but MRI may be very tricky in that area to interpret. So it's not so easy, and recommendations are out, but you really have to follow these patients clinically, is in my opinion. So let me conclude. Appendiceal neuroendocrine neoplasms are rare and mostly early stage, and most of them are well differentiated. The differential diagnosis of more aggressive goblet cell carcinoids has to be considered, and please consider them, because in my practice I see a mixture and a mix-up between these two entities again and again. Tumors of smaller than 1 centimeter are cured by appendectomy. If they grow bigger, consider right hemicolectomy, and in the advanced appendiceal neuroendocrine tumors, you should treat them like the general neuroendocrine tumors. A follow-up is needed. For how long and how frequently has not been really well established. It's a considerable burden for the patient and for the healthcare system, but probably if you do a follow-up, then do it long-term. Thank you for your attention.